Greetings, I'm Dr. Ho-In-sik. Over the course of next several lectures, I'm going to talk about guided surgery. In this first lecture, I'm going to talk about who the guided surgery is for. This is Bill Clinton, President of the United States between 1993 to 2001. While he was preparing for the presidential election, in order to attack his competitor, Bush, he prepared many different topics. He had a lot to say. But one of his counsel, James Carville, said, if you say 3 things, you don't say anything. He told Bill Clinton to focus on one topic. As a result, Bill Clinton came up with this famous saying, "It's the economy, stupid." He focused on one topic. I would like to focus on one topic as well. There are many problems associated with implant. Implant position is what I want to address in today's lecture. Implant, long-term prognosis and complications. Long-term prognosis and complications of dental implant. There are many topics, and today I'd like to talk about problems related to position, and I believe the number of issues related to this is significant. I'm going to talk about long-term prognosis, various complications of dental implant, how these can be addressed with guided surgery. Ideal position of implant. You need to consider horizontal and vertical position. Horizontal position means mesiodistal and buccolingual position. By vertical position, you need to consider the implant placement depths. I would like to talk about 4 things. First, problems related to implant placement position. First, it is buccolingual issue. Second, mesiodistal. Third, implant placement depths. I'm going to also talk about who the guided surgery is for, and after that, I'm going to conclude my lecture. First, complications related to undesirable horizontal implant position. Number 16 doesn't look good. Porcelain chipping occurred. More problematic is in number 16, around the palatal root, a lot of alveolar bone destruction occurred. Extraction was done and implant needed to be placed. However, there is very little palatal bone, and this can lead to many problems. After extraction, 3 months passed, as shown. On the palatal side, bone healing is insufficient. When I placed the implant, the placement position was slightly angulated buccally because it was where the residual bone was. After 3 months, custom abutment was provided and crown was completed. 16 months after loading, first screw loosening occurred. Screw loosening occurred approximately 1 year and 4 months later, and this is quite rare. Early screw loosening occurred. Filling in the SCRP hole was removed, and using torque wrench, I tightened the crown once again. However, 3 months later, second screw loosening occurred. This is extremely rare. I removed the filling once again. Although I tightened once again with a torque wrench, the mobility in the implant did not decrease. Then what could be the problem? Perhaps it is because when I retightened using torque wrench, the crown moved like this and the osseointegration of the implant failed. Although I tightened the crown repeatedly, the crown moved. In other words, rather than failure of osseointegration, you can assume that implant fracture occurred. I remove the crown. On the lingual side of the implant, you can see that there is a crack. I open the flap immediately and remove the fractured component of the implant. And as shown, implant was removed, implant screw and crown were all removed. Why did mechanical failure occur in this area? I think this is the cause. Implant's access hole is slightly buccal. In other words, implant body has been placed buccally or it is slightly angulated buccally. If you look over here, the functional cusp of implant crown is palatal cusp. And you can see that the implant access hole and palatal cusp is very far apart. And if occlusal force is applied to the functional cusp, severe cantilever force can be applied to the implant. In order to avoid such problem, the access hole of implant should be in the middle. That would be most ideal. Then occlusal force will be focused on central fossa instead of functional cusp. Mechanical failure can be avoided if occlusal force is concentrated on the functional cusp of the antagonist and center of SCRP hole of the implant crown, or the central fossa. Therefore, implant placement position is very important. If guide had been used for implant placement, it would have been placed more closer to central fossa. This is a second case. The patient received implant placement from a different dental clinic. The patient complained of severe discomfort on both sides. The implant in the upper right, there was severe peri-implantitis, and implant in the upper left, as shown, the implant position was extremely lingual. The placement position and crown was very lingually inclined. Because of this, food impaction occurred very severely around the crown. What caused this problem? The alveolar width of the patient, it was rather sufficient. Considering the antagonist form, you need to make a crown like this. And considering the position of the crown, implant should have been placed like this, slightly more buccal. However, it has been placed more lingually. Because implant was placed lingually, unsatisfactory implant crown came to be. This is a different implant crown case. In number 17, the crown is slightly palatally positioned. Cervical area of the implant crown is lingually inclined. This is the same for these types of crown. After surgery, a lot of food impaction can occur. This is natural teeth before extraction, and when you compare it with the implant crown, it's rather different. On panoramic image, mesiodistal position is okay. However, the problem is with buccolingual position. Number 14 and 15, the crown axis is well aligned with the functional cusp of antagonist crown. However, number 17, the central axis of the implant is towards functional cusp rather than central fossa, and implant crown shape is towards the functional cusp rather than central fossa. Why did this kind of problem occur? I think because the handpiece position, when we place posterior implant, it is tilted distally. You cannot gain proper sight and patient cannot open mouth very well. In those cases, it is very difficult to control buccolingual position and mesiodistal position. And this was the main problem here. Because ideal crown access was not provided, such problems occur. This is a second topic. There are problems that are due to bad implant placement position. Let me give you an example. Looking at this case, clinically, the implant is placed in an appropriate position for top-down method. Mesiodistally, it is placed well. However, on the X-ray, the tip of the implant in number 46 is in contact with the root of mesial tooth, and therefore the patient experienced a sensitivity. The patient had to have endodontic treatment. In the end, the patient had to remove the implant and place the implant once again. Endodontic treatment was done. Fortunately, 2 years later, no periapical lesion occurred in the mesial tooth. Implant was placed in a new position and prosthesis was provided. In the case of lower first or second premolar or canine in the upper, the axis of the crown and the root can differ. In this case, when you place the implant, it can be in contact with the root of the mesial tooth in a lot of cases. If the mesial tooth is a crown, in a lot of cases, the axis of the crown and root differ. Therefore, when implant is placed, it frequently is in contact with the root of the mesial tooth. Such problems can occur. This is a different case. Number 25 and number 27 implants were placed. I didn't do it. It was done by a different dental clinic. If you take a look here, number 25 is not placed in number 25, but is in the middle of number 25 and 26. It has mesiodistal issue, and if you look at the clinical photo, there's an issue with the buccolingual position. It is very buccally inclined. As a result, peri-implant mucosal problem occurred. A couple of years later, a very severe peri-implantitis occurred and extreme alveolar bone destruction occurred. The patient suffered for a long time and implant had to be removed. If the implant is positioned mesiodistally or buccolingually wrong, these problems can occur. And I believe these implant-related issues resulted due to iatrogenic factor. Third, there can be many issues associated with malpositioned implants. However, I would like to talk about issues related to vertically malpositioned implants. This is in regards to implant placement depths. This is directly related to biological width of peri-implant tissue. When we place implant, if we do not consider the peri-implant mucosa and only place the implant following the alveolar bone crest level, if the mucosa thickness is thick, it's okay. However, if it is thin, in order to gain biological width, the alveolar bone starts to melt away, and if the patient does not maintain oral hygiene meticulously, marginal bone loss could lead to peri-implantitis, and there can be serious problems related to implant. When we place implant, we need to also consider the peri-implant mucosa's thickness as well as alveolar bone. Due to these issues, a very bad impact was caused on implant prognosis. This patient, because of economic reasons, only wanted implants placed in the upper right and lower right. Periodontally, the patient was in very bad condition. If you look at number 16 and 17, horizontally there is enough bone. However, vertically, due to pneumatization of sinus, vertical bone width was lacking. Sinus lift was necessary for implant placement. In the case of lower, vertical bone height and horizontal bone width was sufficient. However, the patient's peri-implant mucosa's thickness was extremely thin. However, it was not factored in appropriately, leading to major problems. After implant treatment, this is the X-ray image then. Abutment height is very short on the X-ray. In other words, the thickness of peri-implant mucosa is insufficient to provide biological width. Even if the patient maintains oral hygiene meticulously, problems can occur, albeit belatedly. However, if the patient does not maintain oral hygiene properly, peri-implantitis can occur with high possibility. A couple of years later, the patient came in. Around the implants in upper right and lower right, severe peri-implantitis existed, and due to that, in number 47, the implant had to be removed. If implants were placed using guide, and if peri-implant mucosa thickness was considered and placed deep, these issues would have occurred much later, in my opinion. I would like to summarize who the guided implant surgery is for by sharing with you a couple of cases. This patient was over 90 years old. In the upper posterior, multiple teeth are missing and implant placement was necessary. Guided surgery was chosen for implant placement. If you look over here, it has been some time since extraction was done and mucosa is quite thin. Guide was placed and tissue punch was used to remove the soft tissue covering the alveolar bone. As shown, peri-implant mucosa, it is very thin. If you just open flap and place the implant, after surgery, healing will take significantly longer, and the patient will experience a severe discomfort, and implant placement depths will not be sufficient. As was with the cases I've shown you, marginal bone loss can occur. However, if you use guide, you can place the implant with sufficient vertical depths. I was able to avoid those issues. I was able to place the implant in the desired position and the desired depths, and healing abutment was connected. The patient healed very quickly because I did not open flap and did suturing, and there was no tissue gap. This is a true advantage in that healing was significantly faster. 3 months later, healing abutment was removed, and if you look at the peri-implant mucosa, there is sufficient biological width, and you can provide prosthesis with ease. This is at the time of tissue punch during surgery. 3 months later, you can see that there is a sufficient amount of peri-implant mucosa. This is the same on the other side. At the time of surgery, the soft tissue thickness was very thin. However, after 3 months, you can see that there is a sufficient peri-implant mucosa height. Scan body was used for scanning. Customizing abutment and crown was fabricated at the same time, and this is how treatment was completed. Guide was used to anticipate mesiodistal, buccolingual, and vertical height. And if you proceed surgery with this guide, you can provide ideal prosthesis because implant has been placed in an ideal position, and many problems can be avoided in the future. This is a second case. The patient was receiving orthodontic treatment. Congenital missing area is here, and implant needed to be placed. In number 15, implant placement was planned. Implant studio was used to determine the position of the implant. If you look at number 15, one cast was used for simultaneous sinus lift. If you look at the adjacent teeth, the canine, the root, and the crown is slightly tilted. If you place implant wrong, it is very easy to be in contact with the root of the adjacent teeth. The alveolar bone, height of mesial and distal area was different, and in that case, it can be very difficult to manage the placement depth. However, if you use a guide, appropriate placement depths can be managed. Guide was designed, guide was placed, a tissue punch was used to remove soft tissue, and implant was placed in the desired position. If you take a look over here, more so than the mesial side, implant has been placed deeper on the distal side. Healing abutment was connected. Surgery was complete. On the panoramic image, implant has been placed in the ideal position. The three implants are all placed in ideal position. You can see that the implant is not touching the root of the canine. Custom abutment was connected, and crowns fabricated at the same time were connected, and treatment was complete. If you use guided surgery, you can place implants in ideal positions, ultimately provide ideal prosthesis to the patients. I would like to give you my conclusion. If you use guide, you can place the implant in the most ideal position. Because this was done based on top-down principle, you can provide ideal implant prosthesis to the patient. Because implant has been placed with ideal vertical position, sufficient biologic width can be secured. Optimum peri-implant mucosa condition can be secured. Fourth, we can avoid many mechanical and biological complications that is associated with malpositioned implants. Finally, guided surgery is not just for beginners, but for professionals with many experiences as well. I believe this is absolutely necessary. This is the end of my presentation. Now we will have Q&A session to address your questions. First question, is guide for all implant indications? I want to use it for every case, however, that's not possible in some instances. There are some cases where guide is not used. If the alveolar bone thickness is very thin, if you use guide, you can get worse results. The reason is even if you use guide, there is a little bit of a gap within the guide. If the bone thickness is thin, the drill can slip and it can obstruct with implant placement. In this case, it is better to open flap, do ridge splitting or GBR to create bone. Once this is done, you can use guide to place the implant and get good results. Second question, what does guided surgery mean for beginner and for professional? For beginner, this is very important because beginners can easily make a positioning error. Guides help overcome this significantly, and therefore, guide for beginner is a must-have. So what meaning does it have for a professional? Because implant surgery can be done more easily, in the case of seasoned professionals, they can focus more on other procedures such as bone graft or soft tissue management. You can shift the focus to other areas as well. Even if you're an expert, it is difficult to place implant with ideal depths considering the peri-implant mucosa and the biological width repeatedly. You can get the correct vertical depths and the ideal position, and therefore it holds a significant meaning to professionals as well. In the beginning, I talked about how I'm going to address guide surgery. Today's lecture was an introduction to guided surgery, and next time I'm going to show you how Implant Studio is used to design guide. Stay tuned. Thank you for watching.